Okay, we'll go ahead and get started. Hi, everyone. My name is Marina Forte, and I am the JH Wiki Program Manager. As you guys can see, Allison is unfortunately not here with us today. She is actually on a flight on her way to another conference. But I am here with you today, as well as Caitlin Rieger, and she will introduce herself in a second. It does take two of us to fill Allison's shoes. So again, thank you for coming in today for our virtual toolkit series. As most of you guys know, we represent 6 distinguished programs dedicated to providing quality and comprehensive family-centered medical care and support services. And we really represent all 6 of these programs listed here. Our vision is to achieve a more coordinated response to HIV care by establishing mutually beneficial relationships. And we want to build upon these existing systems and structures to create that dedicated network of wiki providers. But today, our goal really is to engage and amplify experts. And many of you know that we are here for part 2 of the trauma-informed care, practicing what you preach. And Caitlin Rieger today will go ahead and introduce Adrianne for those of you that were not able to join us for session 1. But session 1 is posted to YouTube, and I will make sure, and I have shared that with all of you, but I will make sure to send that out again after the talk. So Caitlin Rieger, if you would like to go ahead and introduce yourself and take it away.
Hi, everybody. I'm Caitlin. I am the program manager at JHU Peds for the Ryan White program and IPC clinic. And today I'm so excited to be introducing my good friend, Adrianne Martin. She is a highly experienced clinician that comes to us from St. Louis, Missouri. She has been working in crisis response now for over 15 years. She started her crisis work getting her bachelor's degree from the University of Missouri. Then she went on to get her master's from Washington University and continued working in crisis settings, gaining experience with suicide prevention and individuals with acute psychiatric needs. She's worn many hats since graduation, from clinician to trainer to director of 2 different residential facilities. She's now a master trainer in the Assist Suicide Intervention Skills program, and she works as an independent contractor providing DBT services. As if she needs more to add on top of that, she also runs her own private practice and functions as a consultant for several nonprofits, us being one of them. She is doing her best to help us develop skills and best practices in trauma-informed care. So I am beyond excited to hear part 2, and we can't wait. Take it away, Adrianne.
It is so challenging to hear your bio being read. I'm like, oh God, that's a lot. I don't do
All the
too much.
things.
It's a Leo, right? Leos, we just tend to not sit still. Going to get us started by sharing my screen. We're going to talk briefly about medical trauma because all of you are working in the clinic, which means that people who've come to you have likely experienced some trauma. We'll talk about basic needs, meeting those, healthy boundaries, power versus powerlessness with our clients, our patients, and then a trauma-informed care approach with active listening, empathy, establishing trust, and rapport. I always feel a lot of pressure to get through everything, so hopefully I don't talk too fast. Feel free to tell me to slow it down if you need me to. Let's go ahead and get started. While I love introductions, I only have an hour, and so let's jump into this. Medical trauma, what can we do as providers? And we're also going to look at the hierarchy of needs for our clients and patients. And we'll start with a bit of a self-reflection and how each of us in the clinic can be effective with children and families. If a child is in our care, that means a big event has happened, a trauma of a diagnosis, potentially trauma in the womb or trauma in labor and delivery, a chaotic household, medical trauma. So many things have happened. We talked about the ACEs at the last training that I did. So the things that happen in childhood experiences that are adverse to them, that might lead to them having traumatic responses. They likely are hypervigilant. They're coming in, they're already experienced the trauma. So For us, we're looking at education, which is why I believe Marina's has put together this series, and support. That is something that I have been brought on to do, support and guidance, and then care. And for us, it's not just the care that we are providing for others, it's the care that we're providing for ourselves. So one of the things that we're putting together for Johns Hopkins is training to help you all support and care for yourselves as well. So we're going to get started with talking about meeting the basic needs and establishing healthy boundaries. So the right triangle, it talks about the Maslow's hierarchy of needs. So first, we need to make sure that the clients that we're serving are getting their physiological needs met. And I know that there's case management that happens in that clinic setting where they're able to make sure these things are happening. And then we have safety in the home, safety in the clinic space, because sometimes it does not feel safe when we're going into a medical setting. We talk about white coat syndrome, where it's maybe a challenge to even communicate with a person who is of a higher power, which is the person that has the white coat on, right? So if you guys ever hear people or see people freezing up in a medical setting, it's likely because there is this, you are the authority and I don't have a voice. And there's probably experiences that they may have had where they didn't get to share their voice. Then we have love and belonging and esteem and self-actualization. Those are things that go deeper than what we're able to provide in the medical setting. And it also lets us know that these are things for our clients and our patients to strive for. So what are we doing in establishing healthy boundaries? We're using the crisis or conflict that happens in the setting productively. We're using activities. I know that there is a group that was created for parents, and I keep hearing sounds come in. If people can mute upon arrival, that way the little sounds don't distract me. So there's the parenting group that has been happening and bringing activities into the parenting group. So we're giving them those healthy boundaries that they're doing in their household, that they're doing with us as clinicians and case managers, balancing relationships. So balancing our relationship as a provider, as well as somebody who just cares, like we get to give that care, and then satisfying their basic needs as at the top, as we said, the physiological needs, the safety needs. We have that at the top of our pyramid of how we want to take care of them. In that, we want to look at power and authority and how do we establish boundaries or limit setting through our use of power. So one of the things that we think about is when a person comes in, we are that person of authority. We know what's going on with them. We're doing the diagnostics, we're doing the testing, we're taking blood, we're doing all of these things. And for them, it could be really scary because it is how do we respond? How do we interact? Oftentimes that bedside manner, which we'll talk about a little bit later with how we communicate, it can really impact the way that a person can interact with us based on how much power we bring into the room. And so we want to make sure that we are not just overbearing with that power and authority. Yes, we are the person that's the expert, but have you ever been in a setting where somebody has over asserted their expertise because this is what I do, this is what I know? Have you ever been in a medical setting where you're like, well, I'm a medical provider and I know my body and I know my needs and I don't feel like they're being respected? So the goal is to ensure that we're letting people feel respected in our space, that their thoughts and their opinions about their body, their perceptions are being heard. Because if we don't hear them, then we are overexerting our power or our authority and we're not letting them have voice. And the goal is to give them that voice, to say, this is my body, this is what I know is going on with me. So power is defined as that ability or capacity to act effectively. So we're really working on acting effectively. So thinking about how we respond to people when they are in our space, they may respond aggressively if they feel like we are over asserting our power, or they might respond passively. How often do we see both of these in a clinic setting throughout the day? And how do we respond to it? So you guys can throw in the chat different ways when you notice a patient responding aggressively or passively. What are some different ways that you handle that? And you, again, put it in the chat if you're wanting to participate. And then how have you seen power struggles show up? Because those who are institutionalized, they may feel powerless and they want to overassert, or they might feel like they have to shut down because they feel like their voice is not respected. How do we engage them? How do we bring them into this conversation with us? And again, you can throw it in the chat if you want to have a conversation with me. If not, then we will keep going, because the goal is for us to use our power to shape their choices and behavior. I had the benefit of going into a couple of sessions with you all when I was there last year and able to see how our conversation with the client, the patient, how that went and how we were able to shape their choices and behavior, like give them ideas, give them empowerment. So how do we bring that empowerment for them so they're not feeling so powerless when they're in the space with us, so they're not responding or reacting aggressively or passively? Because the thing about reactions is that it is an emotional response when they feel like they don't have any control. If a person has time to bring themselves down and to think about what's going on around them and to receive the information that is being given to them, then they have time to process and not respond so aggressively or passively because they'll feel confident enough in having those conversations with us. So when we're doing this, we're going into trauma-informed care. When we take power and powerlessness of the patients that we serve into consideration, we are using trauma-informed care. Yes, thank you, Caitlin. So we use the strength-based approach where we're solution-focused, not problem-focused, because if we're simply focusing on the problems, oftentimes it can be perceived and received as I am the problem. So if we're able to look at a problem and empower the person that we're working with by giving solutions or asking them to come up with solutions that they know for themselves, because these are people who are needing to figure out how it's going to work with them in their life. How can I get these medications? How can I make sure that I'm taking them on a regular basis? How can I get a job? How can I make sure that I'm maintaining this income so I can pay for my medications? There's so many different things. And if we're only focusing on the problem, and this is something I see in treatment plans often, where somebody's like, these are the barriers to care, and there's not a solution. So it's how do we help them arrive at the solution instead of us giving it to them? So this is, again, us responding and resisting the urge to react. When somebody shows up in your clinic aggressively, how do we react? How many of us take that time to step back and say, okay, I understand why they're responding in this way. They are feeling disempowered, they're feeling unheard, they're feeling misunderstood. So they are reacting. How do I resist my urges to react? And so for us, it's taking a step back, allowing them to vent. And we'll talk about that in just a bit with active listening. We focus on our patient successes, whether it's youth. And I know we work all the way up in the clinic to what, 26, Caitlin? Yeah, so we work up to 26. On top of that, we work with the families. So we're working with people across the age, across ages, right? I don't have another word for that. So we're working with all different ages, and in doing that, we're looking at their success. We're looking at what they can do, things that they have been successful with in the past, things that they are currently doing that we can build upon to empower them to have more successes, and then giving them opportunities. How do we grow from this? And then building on their existing attributes and strengths in that manner. And we do this by actively listening to them. With active listening, we have expressing empathy, building rapport, validating, letting the person know that we're there for them and encouraging them to seek help. This is all like super simple, bare bones right here. And we're working on recognizing our judgments, values, and biases and not letting them affect the work that we do with our clients. As we're going to go over many difficult topics, we want to make sure that we're using active listening. How many of you, by show of hands, feels like you are an active listener? And if I see hands show, that means you might be actively listening to me right now, which would be really cool. Okay, one hand. And Marianne, I feel like I saw your arm move. I don't know if you're coughing, if you're raising your hand, but I'm pretty sure active listening is a skill set of yours, right? So we got a couple of active listeners in here. How many of you feel like I hear you, but maybe I didn't quite grasp everything? If we're sometimes on the I hear you, I'm not grasping, we might be more on a passive listening side. Many times I've noticed that people who believe that they're active listening, they're like, well, I'm listening to you. They're not giving us anything. They're just, right? Their face is more stoic. They're not responding with their body. They're not engaging. They're just listening, which is great that you're listening. And if a person doesn't feel heard, you might get a different response from them. So the goal is to start by expressing empathy with our active listening. And so Caitlin said I practice DBT. I do. We use a lot of acronyms in DBT, and I really felt like empathy needed an acronym. So I made one up. So expressing empathy, we have engaging, asking a person how they're feeling and sharing with them what you're noticing. when we share with them what we notice, we can often pick up on body language and cues. And in that, we start to mirror like the body language and posturing in a way that reflects the words that they're saying, or it reflects the energy that they're expressing, because we have mirror neurons in our body. So we're going to receive their energy. And in that, we want to make sure that we are a calming mirror for them, because we also want them to be able to have their mirror neurons activated by receiving our more calm posturing. So we want to be engaged. So if it's leaning into the client while you're having these conversations, or if it is having a stance that is not super aggressive, but like your hands are down, they're not clenched into fists, your hands are open. It's this open posturing, this open body language. That way they can feel more comfortable with you and mirror it in themselves. It is being present, watching and listening to what they're saying and what they're not saying. So we're having to tune into their hesitations, their pauses, their inflections. With that, we can start to determine, oh, it sounds like you might be feeling this. You might be holding back on something. I am a huge fan of body language. I have been studying human movement analysis because in a person's mannerisms, you can see their stuck points and what they might be resistant to when they're communicating with you. And that is how we start to attune, by feeling that emotional attunement and making it appropriate to the situation. If you're giving or delivering really difficult news, what is your emotional attunement? How are you delivering this? Is it in a matter of fact, no holds barred, like this is what it is? Or is it in a comforting and empathetic way? The goal is to match your tone of voice to the situation. You'll see attunement and tone kind of go hand in hand, because if you are super excited to deliver your message, or you're monotone and you sound like this, you might not bring them into a level of comfort to where they want to receive the information from you, which could trigger aggressive responses from them because they don't understand based off of your tone, based off of your lack of emotional attunement. And the goal for us is to ensure that they feel safe. Remember that safety is a key piece for them, that they feel safe when talking with us and hearing the information from us. We also want to hear them, hear their story. How often do we have repeat patients come in and we just are going through the motions, but we're not stopping to hear what's going on with them? We're so busy imparting this stuff to them that we're not hearing their whole story. If we're doing case management, it's probably even more important for us to hear their whole story. If we're doing conversations based off of some of the behavior that they may have had over the past however long it's been since they've seen us, we need to hear what's going on with them, because there might be something coming up. There might be something that we can see as their stuck point, or hear like they're not engaging in something, and maybe there's different reasons why. And so without us jumping to our own conclusions, we are listening for full understanding. Our response shows them that we care through our words, our actions, and being really authentic and validating them. The goal for us is to make sure that they feel that safety and they don't have that urge to react to us in a way that is not effective for their treatment. The biggest goal is to make sure that they feel they can engage with us. Because if they don't, then we're going to have a really hard time connecting with them. You'll see I have like random quotes and stuff because I really like quotes. And if you like it, take a picture of it or take a screenshot. All right, so the how is active listening. How do we do active listening? By responding to the feeling and grasping their point of view, and then letting them know that we see things from their point of view, and then encouraging them to vent. I know it can be really challenging. You guys probably have a really brief window that you get to actually allow people to vent. And if we are checking our watches because we're so pressed for time, they're not going to feel comfortable having those conversations, because there's that internal like guilt or shame that might be happening. Like, oh, I'm taking up too much of their time and I don't want to say this, because if I say this, then they're not going to have time for me and they're not going to be able to close this conversation. So we want to make sure that they feel safe in venting with us. And if we're not the one that they can vent with in this moment, setting them up with somebody that can listen to them and listen for total meaning. Again, pay attention to hesitation and inflections, and ask what and how questions. We don't want to put them on the defense by asking why questions. Has anybody ever been asked like, well, why did you do that? And all of a sudden your whole body gets like really stiff and rigid, like, what do you mean why? Like, are you questioning me? So that's what happens with our clients and our patients as well, right? If we're asking them why, they're going to shut down on us because they're going to feel judged. If you've ever felt judged by a why question, maybe try a what and a how. How can you change the way that you ask these questions instead of why did you ask that, right? We can shift the way that we communicate by shifting the way that we ask questions. So we have our core active listening skills and then our supplemental active listening skills. So if you are used to just going through the motions, I want us to go a little bit deeper with this. So we're going to label our emotions, which is this process of identifying the feeling that you're sensing behind the words that they're saying, based on the content and the attitude and the tone with which the words are being said. Even if you label the emotion wrong, nobody's going to fault you for attempting to find the emotion that they're experiencing. If you're asking in a way that feels supportive, then you're giving them the chance to clarify the emotion in their own words. This is showing them that you're attempting to understand them instead of just assuming. Again, with mirroring, it's not just mirroring our body language, it's mirroring the things that are happening in their world, mirroring the things that they're saying, the gist of whatever crisis they might be experiencing. This can draw out specific concerns and problems for use in further interactions and for use with the case management. I often think about the case management because when I went there, that was something I experienced more engagement with when I was at the clinic. And so if we have this information, then we can partner you and address those more specific concerns. And this way, when we mirror, we can keep it on topic and in the present instead of jumping to conclusions again. Paraphrasing, you guys probably have heard all of this before, but it shows that you're trying to get their message. And sometimes when we paraphrase or summarize and repeat it back to them, it allows them to see what we are hearing and seeing from them. Oftentimes they can say, oh, that is not what I meant, or that is exactly what I meant. And they get to feel super heard and validated in that moment. We also like to use these supplemental active listening skills with effective pauses. With the effective pause, it's a deliberate silence before or after meaningful comments from the person that you're working with, or it allows them to focus on what you just said. If we are just giving information after information after information, we're not giving them time to let it sink in. If you think about the way that we all have different learning styles, how many of you have ever just had information overload and info dumps from clients or patients, and you're like, I didn't have time to catch all of that? Imagine, yes, Marina, imagine if you are the one giving that info dump and you have jargon, right? You guys are providers, you guys are giving this information that they may have never heard before, or it's really not familiar to them. So be okay with the pause. They say silence is golden, and it's not this ever like lasting silence. It's a brief silence to let it register. There are different learning styles. There's visual, auditory, reading, and then kinesthetic, right? So if we have these different learning styles, then we're giving only that like auditory information to them. And when we're doing that, if they don't have time to process it and chew it a little bit inside their brains, it's going to be really hard for them to take in and receive all the information. So even though we are like the experts in what we're doing, we need to make sure that they have time to process and put it in their own words sometimes. Minimal encouragers. If somebody's telling a story, we are just nodding our head and smiling, right? Like, I am listening to you. How many of you sometimes notice yourselves having, in my teenagers that I work with terms, RBF, right? We have this resting stoic face. I'll say that word instead. This face that doesn't allow for people to want to continue to speak with us. Shift it, right? We can do a half smile. We can do a full smile. We can nod our heads. We can lean in. We can say, tell me more, right? Minimal encouragers where you're not overpowering the session with your patient. You're allowing them that space and opportunity to give you more information, helping them feel more comfortable, releasing some of that power dynamic and giving them that space to really open up to you. And then using open-ended questions, not just yes and no questions, not just why questions, but the what, the how, can you tell me more about this? That way they feel more comfortable with you instead of feeling like you are just the expert that doesn't believe the things that are coming out of their mouths, or you just want to get your job done. That is really difficult for people who are trying to connect to their provider. And if we want to build these relationships where they come back, where they want to come back and they look forward to their next appointment, I mean, how many of you love your medical providers? You show of hands. I love my dentist. My dentist is awesome. Most people have terrible relationships with their dentist. I love mine because he does this like communicative thing where I feel like I can come in and just say everything and he's going to hear me. And there's like no power struggle there, right? We don't want power struggles with our patients. We want to make sure that they feel just as comfortable with us as we feel comfortable delivering our information. Also, we feel more comfortable delivering our information if they're receptive, right? And then we use iMessages if needed. And in these iMessages, if somebody is getting aggressive, we can say, I may not be feeling like you're hearing me right now. It sounds like you're getting upset. Like, I don't feel safe continuing to give you this information if you're going to yell at me instead of stop yelling at me. You're doing too much. So figuring out ways to communicate that they don't feel attacked in your responses to them, because they are often more escalated because of the trauma that they may have experienced coming into this. And I do know that there are situations where people come in and they are pretty aggressive because this is hard for them. And maybe it's the older ones, maybe it's the family because they want to get that information. And I've heard that sometimes we don't know how to respond. So if we respond with, okay, how do I want to receive information from this person? And if I were this person, how would I be open to receiving this information? The biggest thing that I like for people to look at is, if you were the patient or if you were the family member of the patient, how would you like to receive these messages from your provider? And really tuning into that I message, like, okay, if I were this person, what is my value? And my value is this. In that, we can really build our trust and rapport. The quote here is, the best rapport arises not out of some direct effort to get along well with in this quote it says caller, but the patient, but out of a simple and sincere effort to listen and hear accurately to what they have to say. So in rapport building, we're establishing that this person feels listened to, they trust us because we're giving them truthful information, we're adhering to our values, we're respecting their values. And when we respect their values as much as adhere to our own, they're ready to listen to what we have to say. And we can address any distorted thinking by putting a different spin on things and helping them identify with us, like as humans, not just as the white coat professional. When a person comes in and they have experienced a medical crisis or they've experienced a trauma, they need to feel a connection to us. So this is super valid or valuable and important information so that they can trust us and speak without feeling judged. And without the previous stages of active listening and empathy, this connection is likely not able to happen. So we have to recognize the key elements here, like our words that we use are just a little bit of what gets our message across. The tone of voice and our body language make up the rest of it. You see the pie chart here, like we are really trying to bring our energy into the space to make them feel safe with us. So we're using our tone of voice, we're using our body language, we're being open, we're not having, like, again, the resting face that says, I don't care, I'm disinterested, I don't want to be here, I'm just ready to get off work. What time is it? It's almost 5 o'clock, it's time to clock out. Being able to be 100% there for them with our body language and our voice tone. With this, we're able to communicate acceptance, which is validation. And validating them, I love the term that people don't just need validations like because they need it, it's because they deserve it. Oftentimes people come into us and they haven't been validated. Their fears, their worries, their concerns, their deepest, darkest secrets that they're entrusting with you because of whatever's going on in their life, they need to feel a level of trust and security with us in order to communicate with us. So by us validating them, it allows them to see that we accept them, and validating their feelings, offering them a safe space to open themselves up to us and to feel vulnerable, because we need information. I mean, how often do we recognize that our patients may not be telling us the whole story? And in not telling us the whole story, we're not able to serve them as fully as we would like to. So we have to show them that we accept them as they are by providing them a validation. So there are different levels of validation. The first one, as we saw in the empathy acronym, is being present, being 100% present. Also in the acronym, we are mirroring and reflecting back the way that they feel. We're offering them, like, this is what I see in your energy. I'm wondering if this is how you feel. So we're not just reflecting back the feelings that communicate, we're also reflecting back what we see. based on their history, we also want to be able to say, okay, I'm noticing this response, and based on your history, this response makes sense, right? So a way of validating is by historical reference. If you've known this person for quite some time and they've been coming for a while, or if you know their history based on their intake paperwork, being able to say, it makes sense that you would be scared to talk to me. It looks like you've had some trauma in the medical community in the past, and I want to make sure that you feel safe to communicate with me. By even saying that, they are feeling validated and they're like, oh, you know that everything is not all peachy keen and like shiny, right? All that glitters isn't gold. So they want to communicate with you because you've been able to recognize that. You've also been able to normalize that they might be experiencing fears that anybody in their situation would have. So we have present, being present, we have reflecting back their emotions, the ones that they verbalize, the ones that they don't verbalize, reflecting back acceptance based on their history, and then normalizing. And the last way to be validating is to be authentic. So we are being our authentic self, showing up for them in a way that some people may not feel authentic showing up for them as. Some people might struggle with that authenticity. So don't do it in a way that doesn't feel authentic to you. Because if you don't feel authentic, then they're not going to feel connected to you. They're going to be like, okay, you're just saying this like you don't actually mean it. This is just your job. Like, yeah, this is my job. And I'm doing this because I care. So making sure that they feel like whatever you're bringing to them, this is you taking that like great sense of inner security in the job that you chose and the career path that you chose to help these people in a way that you feel good about. And that is what helps them connect with you by being a validating presence and an authentic person to them. So when we're talking with them, when we're getting to know them and we're developing this rapport and creating a supportive environment, we're not doing like rapid fire questioning. We are making this, I guess, interview process. I call it interviewing because I feel like when we go in as providers, we have to ask a whole bunch of questions to get a bunch of information. One thing I noticed when I worked in a hospital setting years ago is that they had 3 or 4 pages, I believe, of assessment. And I was like, this feels like just like rapid firing, like in order to get it all done. So I had created a 1 pager for myself to go in and talk with them. And I just would have conversations with them, building in the educational statements where it's like, oh, I'm hearing you say this. How can I educate you based off of what I'm hearing come from you? Or in building in those educational statements, I'm also normalizing some of it. I'm making the conversation a supportive one instead of one that is, I'm the professional. Again, that power dynamic is not as important as the authenticity. You're building in your reflections, showing them that you're listening. And yes, you let them know I may be jotting things down that are important while we talk. You're going to get your documentation done eventually. I know you are. You guys are all professionals. So I know that that's a thing that you have to do. Documentation is important. And being present and taking little notes, not being strictly bound by the questions and letting the questions flow naturally. Again, not rapid firing. Avoiding power struggles by honoring their story and giving them time to tell it. Again, I don't know your time constraints all the time. In my mind, I just imagine providers have like 15 minutes to get everything done. When I worked at a hospital, it was more relaxed because it was on the psych unit. So working on the psych unit, I could kind of float in and out of rooms and make things happen as needed and and by honoring the space of the patient instead of I got to get this done and I got to get my paperwork done and blah, 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 blah. So avoiding the power struggles of getting them to answer the questions, but honoring them and allowing them to tell the stories in the way that they feel comfortable. And by building the trust and rapport, we're able to get them to tell these stories in a more like succinct and concise way, hopefully. Letting them talk. As you see, I keep acknowledging we don't have all the time in the world, and we don't want to make them feel rushed to say my schedule is more important than yours, because that again can create a power struggle. And knowing that these people have experienced trauma in the past, we want to make sure that they don't experience it through us. We want them to come back. I feel like Caitlin has talked to me a little bit about how it can be really hard to get people to come back in, especially if they did not feel super comfortable. And this doesn't just like start with you all. This starts from the walking into the clinic, like, right, getting through check-in. So even talking with the people at check-in, the security, the front desk people about how they can develop rapport, because if they're going to work there, they're going to see these people more than just this one time. So helping them discuss concerns that people might have and not just like being a like a ticket told, like I'm number 1 or I'm number 32. Like we want them to just feel like a number. Hi, Jen and Megan. Yes. Sorry, y'all. Okay, and then lastly, I feel like I talked really fast. I've usually make this like a 3-hour training, so I'm glad that I was able to get it in this small amount of time. But creating safety in the clinic by using our power wisely. So when we start each intake and appointment, we give them a voice, we give them opportunity to share their concerns. We discuss any expectations we might have for them. We check in to make sure that they're feeling safe in the facility. Again, our bedside manner is super important. Not that they're staying with you. It's not like they're in a bed, but that's just what I think of when I think of clinics. And then allowing them to express their emotions without repercussion. They are going to be angry. So what happens if they're angry? If we hear them and we don't project or personalize what they're saying, like project our own thoughts and feelings onto them or say, oh, they hate me. And then now we're getting defensive and we're getting really upset about it as well. We're able to allow them to express their emotions without this repercussion. And in doing that, we're allowing them this responsibility to be open with us. And we're upholding the expectations that we can actually hear them. So I know that there are times where there's like belligerence that can happen. And I worked in residential for quite some time. So I definitely know what it's like to be yelled at, maybe cursed out a couple of times. I was always been like, oh, what's the worst you can say, right? And if it's just words, how can we reassure them that we hear them, that we respect them, and that we are giving them the care that they need based on what they came in here for? So making sure that we check in with them and say, this is what I'm seeing, actively listening, building that rapport, we can reduce the reactivity of the people that we're working with. And again, I had a whole bunch of slides and still I overtalked and was really quick, like I was last time. I'm doing really good at talking really, really fast. So this gives you all the opportunity to get back to your days, but I would like to open the floor for any questions.
First, thank you so much, Adrianne. Another like all-star presentation. I appreciate you. I will start off questions. Here in the space that we work in, we serve, primarily pediatric patients, and we have specific safety concerns when it comes to adolescents and pediatric patients. And I wonder if you can address, how do you make a space feel safe for an adolescent patient that like wants to tell you something, but mom's in the room, or like wants to build rapport, but can't have that control and autonomy over their visit. Do you have any like suggestions or thoughts on that?
Are there ever any reasons why we would want to remove the parent, like, oh, can you come with me to come fill out this paperwork, instead of saying, we want them to speak alone? I do know as a therapist, when I see teenagers and their parents come to a first session, I'm usually like, hey, teenager, you have this wonderful autonomy of being able to speak to me while your parent is here, and then you get to kick your parents out the room because it is your safe space for you to be as open as you want to be. So I can imagine the reason why people would come to your clinic, parents would want to be there in that space, and it could build so much trust and engagement to give that teen that responsibility and that right to say, hey, I want to do this on my own, mom or dad, like, or caregiver, and ask them to leave the room. And then you give them a, hey, why don't we come out, and then give them like paperwork to fill out. Like, this is exactly what we want to happen. We want them to start speaking up for themselves and their appointments. Here's some paperwork for you to fill out while they're in here, even if it's not the most needed paperwork, right?
Yeah, I think that's a fantastic suggestion, and I've seen some of our providers navigate that way. I also know on the flip side, there's some of the safety concerns that come with like actual physical safety and confidentiality. And I know even personally as a clinician that like having to, report something or, intervene in some way if someone's having like suicidal ideation or something, that you have to maintain that safety, but it can also feel like a breach of your relationship. So on that side of things, how do you navigate that?
So for my clients, when I work with them, again, I'm really big on working with adolescents. That's my favorite population to work with because if you all remember when you were adolescents and you didn't have a voice, you get to be that person to help them find their voice because they are autonomous humans. And at age 14 is typically the age where I say, anything you say to me in here is confidential, except if I feel you're at risk of hurting yourself or somebody else, or if you're having suicidal thoughts and I feel like you need additional interventions. I've had teenagers where they have had suicidal thoughts and they've had absolutely no intention of acting on them, and we created a safety plan. And that safety plan, I encourage them to include their parents. That means they're still making the decision. It's almost like saying, hey, do you want to eat vegetables for dinner? And they're like, no. And you're like, hey, what vegetable would you like? Would you like carrots or broccoli? And they get to make a decision. So it's like, hey, how would you like to incorporate your parents in the safety plan? Would you like me to reach out to them or would you like to? And that way they get to say, you know, I feel more comfortable doing it myself. Can I ask them to come back in? Or they could say, can you do it for me? I'm really scared. You're still getting what you need, the parent buy-in. You're not forcing them to tell, and you're not telling on them. You're looping them into the collaborative safety approach.
I appreciate that.
One of my favorite things to teach.
Yeah, no, that's fantastic. I have plenty more questions, but I want to make sure that we get to other folks if there are other questions.
Yes,
If you want
please,
to
I love questions.
put them in the chat or feel free to unmute and go for it.
Open to any question. I like questions. Okay, so yes, having parents step out. Is there a way, Marianne, that you've been able to do it where the parents are like completely okay, or do you ever have parent pushback?
Definitely have parent pushback sometimes, but um I introduce it that this is standard practice and that what we're going to do is, do you have any concerns that you want to let me know about? Excuse the parent and also tell them as I'm excusing them, and then we'll bring you back at the end and have you so you can hear how things went. But my caveat with that is saying to the teen, I prefer for you to tell your parent what happened. And you can say as much or as little as you want to. But what is more concerning now that we're all having to grapple with is this new HIPAA stuff although parents can have proxy access to their charts of their kids, there's some coercion in a lot of families of the parents having the child sign the proxy access so that they can see all the private stuff. And there's also a new thing with HIPAA that the parents can request a copy of their child's entire record. And so things are not as private as they used to be in a lot of ways. And I think that I don't know how much the kids are aware of it and not aware of it, but it's something that as a group we really need to look at.
That actually is good information to hear because how do you communicate that, or do you communicate that with the teens after their parents have left? Like what you say in here is private unless your parents request this access, and then how much of what they are telling you needs to be documented?
There is a way we can shield the stuff that they see via proxy access. Although the rules around that are very specific in terms of it's only if it would be harmful to the patient.
Mhm.
And you have to have, and it can be life-threatening, or I don't remember the wording of all of it, but
You have to justify it.
yeah, it's not as private as it used to be, which really is a barrier in a lot of ways, to the way I've practiced my whole career, at least with respect to teens.
Yeah. And that safety piece is the piece that kind of was talking about just a little bit earlier, like letting them know if you are at risk of hurting yourself or somebody else. That is something that, regardless across the board, has to be reported. And if they are somebody who self-harms without the intent to cause suicide for themselves, like there are times where I don't talk to parents about that because I know my clients. So I have clients who self-harm in different areas, and we talk about the areas of self-harm at. And then when it becomes a risk, I'm like, well, I want to tell your parent because I'm concerned, and I want to know if you would be willing to tell them or bring them into the conversation. So it's being really open with them, like about my concern, right? Like we are humans, we care about you. We are wanting to take care of you, make sure you're safe. And for me, if you're coming to me, you have committed to life for at least a year while working with me. So for you all, you're trying to keep them alive. You're trying to keep them safe. And in doing that, it's saying this is the agreement. When you come here, the goal is to keep you alive and to keep you safe and to keep you healthy. And if I think what you're doing is not going to reach those goals, then we need to talk about what the next steps are. I absolutely do not believe that my teens ever tell me less because of it. I think my openness and my honesty about what I do have to communicate is what. Oh
I
no,
need to
Mary.
go. They
Okay.
found one of my husband's grandchildren dead. Um, I'm sorry.
Well, we're sorry. Wow. Okay, Marianne.
I just got a message.
Yeah.
Yeah,
Best of
Bye,
luck with
Marianne.
thank you.
everything. Prayers are with you.
Sorry.
Sorry.
Bye.
Bye.
Bye. Well,
Oh,
that was unexpected.
speaking of trauma.
Speaking of trauma,
Whew.
if you all can take care of Marianne after this, that's scary. Um, and not to make light of that, but to go back to what you're saying, Marina, is I do not feel like I've had anybody speak less to me about it. I actually feel like my honesty is why they just come out. Also, when my teens are over the age of 14, if they're engaging in like drug use, unless it's harmful to them and it's so risky that they are not safe, I also don't have to report it based off of the code of ethics, which to me used to be a really big brain screw, but now it's like, okay, I can get you to sobriety without having to engage your parents, because what happens is if we engage the parents, they actually become a bigger risk to themselves safety wise because of the trouble and the punishments that come with it and the hopelessness and the feeling of being trapped. So being as open and honest as you can with your clients is very key to getting their trust. And Brittany, I'm reading your comment. Yeah. So Brittany, what's interesting is we have, when I used to work in foster care case management, if a parent would request access to the full files, we would redact things that don't need to be seen by the parents. Like there are certain things, certain comments. Also in documentation, I do believe you put what's needed. And if you have, I have paper documentation, so because I'm still old school, I have a computerized system, but I keep my paper documents because it's my CYA file. So I'm covering my tail as much as possible. Also making sure that what is needed to know goes into the file, and what's not needed to know, which is information just strictly between me and the client, patient, therapist, confidentiality. So whatever works the best for you all in your practice.
I think, Adrian, one of the areas that I'm thinking it can get murky, especially with our patient population, is sexual relations and activities and experiences, and like that's something that you may want to document medically because it has medical significance to like their risk profile, or even why you're treating them the way that you are. But they might not want mom or dad to see that, and I don't know where the line is in being able to say, like, no, we're going to shield this from the chart or for mom and dad when it is like sex related or drug related or something like that. I don't know kind of how far you can take that justification. But I can imagine that that's one of those areas where it gets kind of murky, because if mom and dad can read your chart and can read why you're getting XYZ prescription, or, the summary statement that says like, talk to patient about birth control or something, like even that could be, hazardous, I think, to the patient sometimes.
And that's knowing their household. Is there abuse in the household? Is there a risk of abuse in the household? And in even prescribing birth control or talking about birth control with a client or a patient, you can put it under sex education, right? So how do we define what it is? They're at a certain age, and that is policy, right? To provide sex education. If they are coming to your clinic, they are likely needing some sex positive education as well. And so it's not client engaged in risky behaviors, talk to them about birth control. It's provided education on birth control.
That makes sense.
It's how we word it. It's strength-based wording versus punitive wording. We're not trying to punish them for being sexually active. If their risky behaviors are prostitution or putting them at risk of like being injured, that is something that I think would need to be a conversation that a parent needs to be looped into, because that's risky, not just for them, it's risky for the household. Because if you're doing this behavior, it could carry into your household. It could create harm to somebody there just based on who you might be interacting with. I have been told about the main streets of Baltimore, so I would imagine that we want to make sure that we're keeping people safe. So I would believe that having those conversations, again, looping them in as, how would you like to address this? Would you like me to address it with them and how to keep you safe, or would you like to bring them into the conversation? Because what kind of therapy might be needed if you are engaging in this behavior? This risky behavior is likely based off a trauma that hasn't been processed. So getting them referred out to a therapist or particular therapy modalities because they need that, versus I just want you to have that because I want you to be safe. No, there's something that's not being addressed here. And as a clinic, you can only address so much. If you're not providing weekly therapy, then they need to be referred out to somebody who can.
Absolutely. I know, Adrianne, you and I have talked about this a lot, but something you said reminded me of it. How do we resist the urge to react? I think sometimes, as providers, as clinicians, we have great intentions and we have great solutions and resources like at our fingertips sometimes. And I think we almost get caught in like the I hear you, but and I'm wondering if you can kind of speak to that at all, and what that does to empowerment, and we've compared like empowerment versus I can't think of the other word, but
enabling.
Yes, thank you.
Yeah. Well, if I have the urge to react, that is kind of like the last slide that I had shown. Is my reaction, is it based off of like maybe I am feeling personalizing it, right? Like I am thinking of you as somebody who I care about, and this is like some behavior, and maybe I am now like counter transference and thinking about if this was my kid, and we start building these stories in our head that create this more intense reaction. And it's like, this is what they're bringing to me because they trust me and they feel safe conversing with me. If I react, how will I break that trust? What will that do to them interact with me in the future? And is my reaction based off of my countertransference? Is my reaction based off of personalizing it? Is my reaction based off of I was shocked, right? Or are they looking for a reaction? I mean, if you've ever worked with teenagers, sometimes they want the reaction. So I have very
Shock and all, baby, shock and all.
right. Sometimes the shock in itself is enough for them to feel satisfied. And it's because sometimes there's no reaction to them. So they might ramp it up a bit to get that reaction, especially because of the situation they're in. So asking them what you want, when you said this to me, what were you looking for? What is it that you need from me when you say these things? Would you like resources? Would you like to start therapy? Asking them, reflecting back, because sometimes when you reflect it back to them, again, that mirroring, that paraphrasing, that summarizing, all of that allows them to see what they just said. And they can say, well, I don't really know what I wanted when I said that. And they may not.
Yeah.
So they don't know what they wanted. How can we react and shut them down to where now they don't want anything from us because we've now reacted because we have no control over it. Like reactivity is basically, I don't have control over this. So I don't know how to respond. By taking a step back and giving them space to clarify, it helps us respond a little bit better. I always joke about my ice water that I keep with me. If I feel the urge to react, I just take a sip of my water and I bring myself down and a little pause and I'm like, okay, what would you like from me after that statement? Like, is there a resource that I can help you with? Because my agenda may not be your needs. My agenda might just be what I feel like you need.
Yeah. Yeah. And I think sometimes when, you do have resources and things like that, it's easy to want something for somebody else. I always have, talked to my supervisees and things like that. Like, you can't want something more than your patient or your client wants it. And I think you did a beautiful job of showing us today how to balance the reaction of empathy and that validation piece while still giving folks the opportunity to have control over their own stories, be experts of their own lives. And we just appreciate you being here today and want to thank you so much. We can't wait for you to be here next week.
I'm excited to see y'all again.
Thank you, Adrianne.
Thank you.
Thank you, everyone, for joining us, and we'll see you guys next month.
Yes, thank you all for joining. Good to see familiar names, not faces.
Thanks, Adrianne. See you later.
All right, see you guys.